This is Jamal Saleh again discussing the psychiatric evaluation. This is the second of two-part to the psychiatric evaluation discussion. I left off talking about the differences between an inpatient and outpatient setting evaluation. To discuss the inpatient, now we'll move into the outpatient. Outpatient evaluations tend to be shorter, offer the patient greater autonomy, and give the psychiatrist or mental health professional an opportunity to monitor the patient over a longer period of time. And then there's, of course, involvement of family and significant others in the evaluation, which kind of help bridge the gap a lot of the times, that the psychiatrist gives the provider knowledge about the patient's condition, and then could be otherwise obtained through an intense evaluation at a hospital. Much like the general medical evaluation, with its well-documented history and physical format, the psychiatric evaluation is no different, and it's structured the same way. In particular, it begins with the presenting problem, which is the same as the chief complaint, followed with the history of present illness. This includes symptoms and syndromes, history of worsening and remissions of symptoms, and stressors and possible triggers. Next is the personal psychiatric history, and this includes a chronological summary of all previous episodes of mental illnesses and details of a patient's past treatments and responses to those therapies. And then after that is followed the general medical history. This includes information about any known illnesses and hospitalizations, including procedures, treatments, medications, and includes any relevant information regarding significant injury or trauma in the past, sexual reproductive history, history of neurological disorders, allergies, drug sensitivities, and conditions that have caused any pain or discomfort for the patient that could have a role in the presenting psychiatric symptoms. Followed after that is the family history, which includes psychiatric histories of the family. Particular attention is paid to any family history of mood disorders, psychosis, suicides, and substance abuse disorders. Treatment in response to treatment on the part of family members is also explored. Followed after that is the history of substance abuse. This focuses on both legal and illegal substances, including alcohol, caffeine, nicotine, marijuana, cocaine, opiates, sedatives, hypnotic stimulants, solvents, hallucinogens. After that is the psychosocial and developmental history. This is probably, the developmental history part is probably more important for the child. This includes review of stages of the patient's life, particular attention is paid to milestones and how the patient has responded to the transitions from one milestone to the next. After that is the social history, and here particular attention is paid to relationships in the patient's life, relationships with significant others and other family members, and the living arrangements. Followed after that is the occupational history. Of course, some jobs have different physical and psychological stresses, and these play a role sometimes play a role in the patient's presenting symptoms. This again is of note is someone who has a military history, which is important. And then the final part, of course, is the physical examination and testing. The physical examination is used to assess the patient's general medical status, including their neurological health. Health information can be revealed also by blood tests, x-rays, special assessments such as psychological, educational, speech, and language tests. As part of the mental status examination, the psychiatrist will conduct as part of the psychiatric evaluation, the psychiatrist will conduct a mental status examination, and it serves as the same purpose as a review of systems. It'll observe the patient's behavior before, during, and after the interview. This includes the patient's appearance and behavior, expressions of mood and affect, characteristics of speech and language, the rate of movement, presence of any purposeless, repetitive visual movements or postures during the interview. Patient's thoughts and perceptions are also considered, including any worries or cognitive perceptual symptoms related to specific mental health disorders, any violent or self-injurious thoughts. Assessments of the patient's cognitive functions are also noted, including the level of consciousness, language function, attention, and concentration. That's another essential part of the psych evaluation. All this data is collected, including data that's gotten from nurses, psychologists, therapists, social workers, counselors, case managers, and are analyzed, and the psychiatrist uses guidelines outlined by the DSM-4 to make the appropriate diagnosis. And one final note is at the end of the evaluation, the psychiatrist, of course, leaves room and time for the patient to ask questions of the psychiatrist, and the psychiatrist will answer those questions to the best of their ability. And follow-up appointments are set up after that with any assistance from other healthcare providers. That is the end of the psychiatric evaluation.